Hi, my name is Sara R. I'm a student nurse midwife at University of Nevada, Las Vegas in the School of Nursing, and I'll be presenting implementing skin to skin in the OR after cesarean section and a labor delivery recovery postpartum unit, a quality improvement study. Skin to skin is very important to the birthing person and the neonate. As part of the Baby Friendly USA initiative, skin to skin is done routinely when safe after every vaginal birth, but is not done routinely after a C-section. Skin to skin offers benefits to both the birthing person and the neonate. It helps reduce pain for both, stabilize glucose and temperature levels in the neonate, helps better transition the neonate to external life, and it helps bond the dyad as well as establish breastfeeding early. The local context, this study will take place in a community hospital in Southwest Washington in a labor delivery recovery postpartum or LDRP unit. The unit has 13 beds with 14 inpatient beds for the LDRP part. They have 2 ORs in the back and 1 special care nursery. They only have the capacity to take care of 35-week gestational age or older neonates. If there's a 34-week gestational age or younger that is born, they are shipped to a higher level of care. And the special care nursery does not have the capacity to care for neonates that require an IV, antibiotics, dextrose continuously, or any enteral feeding. They average about 60 to 80 births a month and about 730 a year. Scheduled and emergency sections that were performed monthly in 2022 were 17% and 19% in 2023. There are 2 women's clinics that feed into this LDRP unit with 6 OBs or trained surgeons that are on call. Each have a rotation. They are not in-house at night or the weekends. There is a CRNA on site 24/7. We use CRNAs and not anesthesiologists. There are about 42 nurses that work between day and night shift. 6 of those have been trained and certified as lactation consultants, mostly on day shift. And there's 1 to 2 OB techs per shift that work. There are 2 pediatric clinics, and those doctors rotate and take call. One is through a family practice, and the other one is a child and adolescent clinic. Again, the pediatrician is not on site. They do round on the babies after they're born, usually the next day, and they're only called in if we feel like the baby will need resuscitation or help after delivery. And the C-section established breastfeeding rates at discharge about 48 to 72 hours after the C-section. In 2022 was 15%, and in 2023 was 12%. Those numbers are going down. The purpose of the study is to establish skin to skin immediately, if safe to do so in the OR, and increase established breastfeeding rates in the C-section population. The project questions: does training the interprofessional team on skin to skin immediately in the OR increase their support for skin to skin in the OR? And the other question: does engaging in skin to skin in the OR increase patient satisfaction and establish breastfeeding rates on discharge? The objectives of this project is to increase the interprofessional team's knowledge and participation in immediate skin to skin in the OR, and to increase established breastfeeding rates with the C-section patients and increase their satisfaction rates. Within the literature review, there's 3 really good studies that were found. As you can read here, they were successful. The first one focused on the length of time, and they said their time was for 15 minutes with skin to skin in the OR, and they overachieved at 42.5 minutes. The second study focused on breastfeeding, and their rates rose from 8 to 19% for those that had C-sections and skin to skin immediately in the OR. And in the last study, as you can see, 60 out of the 583 birthing people that had skin to skin in the OR within a 90-day period, 57% of those did have skin to skin, and they did not require additional pain medication. The increase of patient satisfaction rose to 84% within that study. The strengths of these three studies: there was clear evidence of training of the nurses on skin to skin immediately in the OR, and an increase in patient satisfaction with breastfeeding rates. The gaps: none of the studies were done on an LDRP unit, and none of them were done in a small hospital in Southwest Washington. The methods: there will be a pre and a post intervention study or surveys, and then we will follow the PDSA, or Plan, Do, Study, Act model. Each PDSA model will be about cycle will be about 3 months, and within the plan cycle, we will meet with leadership to establish goals, evaluate costs, budget, evaluate the material for the evidence-based practice. For literature, that will be a part of the education of the interdisciplinary team, and develop a flow chart algorithm to be posted in the OR to help guide safe decision making for skin to skin. Within the Do, we will survey the staff before the education to get their baseline of how supportive they are of skin to skin in the OR. And then next, we will try the process of skin to skin and the OR, and survey how well it went with the staff and the patients. Within the study cycle, we will evaluate those surveys from the staff and the patients, noting where there are barriers and limitations to skin, or where there was dissatisfaction within the process. And in the ACT phase, we will evaluate all that gathered data and evaluate for suggestions for improvement, rework the algorithm if we need to, and fine-tune the literature for staff education, and then we'll try it again. Setting and the participants, again, will be in this LDRP unit with 14 beds and 2 ORs. It will be an inpatient LDRP nurses. There's, like I said, 42, about 6 OBs, and about 9 CRNAs. The inclusion criteria will be full and part-time nurses, so everybody on the unit besides our PRNs or per diem nurses. The intervention will be skin to skin in the OR immediately after C-section, education from studies and the best practices. There will be 4 half-day trainings offered at different days or times of the week for both to accommodate day and night shift nurses, as well as our OBs and our CRNAs. Recruitment: there will be information sessions during a staff meeting. There will be flyers posted in non-patient areas advertising the class, like the break room or in the bathrooms. Emails will be sent regarding the training. The training will not be mandatory, but we will pay the nurses their regular rates for attending the training days. They just need to attend one day, one half day to get the training. The data will be collected. So the measures, the staff will have a pre-education support survey. It will be 5 questions asking their interest, support, and limitations that they see to or interest in skin to skin in the OR. And then there will be a post C-section survey for the staff. 5 questions again, or the success or the limitations to skin in the OR. The patients will also get a survey, 5 questions, how satisfied they were with the process, any limitations, do they start breastfeeding, and do they plan to continue breastfeeding after they go home. We will track the number of C-sections that we do each week, and how many were able to do skin to skin immediately after the neonate was born. We'll have a pre-intervention data collection and a post-intervention data collection and we'll do those 1 month and at 6 months after the training is completed to establish skin to skin in the OR. Methods, the pre-intervention and post-intervention data, readiness and support from staff on skin to skin in the OR, the C-section rates. We will compare staff and patient surveys on success, satisfaction, and limitations, and compare patients who had C-sections with skin to skin in the OR and those who were not able to because the baby wasn't stable or they chose not to, and compare their breastfeeding establishment rates. With the ethical considerations, we will go to our institutional review board at the hospital and make sure that they approve of this study. We will also not do skin to skin immediately after the baby's born. If they are not stable, it'll be kind of the same algorithm that we do after a vaginal delivery. If baby's blue, listless, floppy, not breathing really well, we're not going to put that baby on the birthing person's chest. We will take it to the warmer and start resuscitation processes. And then, of course, there'll be informed consent will be obtained from both staff and patients if they want to participate in this study. Training is, again, not mandatory, and attendance to the training will be compensated with the hourly rate for the nurses. With the implications, nursing practice will change in the OR with the establishment and implementation of skin to skin in the OR immediately after birth to improve the neonate outcome and establish sustained breastfeeding, and improving support from stakeholders within hospital leadership, nursing staff, OBs, CRNAs, and pediatricians. Nursing policy will change. The results of this study will influence the policy and be able to make revisions for skin to skin in the OR, and there will be a task force that will be in charge of the algorithm. With the results of our study, they can then be applied to improve both the algorithm and the policy for skin to skin in the OR. Here are my references. Thank you so much for listening.